Hi everyone, welcome to Dr. Deepa's Learning Launch. Today we will discuss the beast among the thyroid tumors, which is the anaplastic thyroid carcinoma. So this is a whole side image which is showing you the features of the anaplastic thyroid carcinoma. Anaplastic thyroid carcinoma is one of the most aggressive of the thyroid malignancies, and it is derived from the undifferentiated follicular thyroid cells. It accounts for less than 5% of the thyroid carcinomas and yet contributes to more than half of the thyroid cancer deaths yearly. In most cases of anaplastic thyroid carcinoma, they arise from the de-differentiated, pre-existing, well-differentiated thyroid carcinoma, such as a papillary or a follicular carcinoma. In fact, there can be areas of de-differentiated thyroid carcinoma which can be found in 80 to 90% of the cases. Common early driver mutations include those of BRAF and RAS, while TERT promoter and TP53 mutations appear as late events in these tumors. So that the late promoters of TERT and TP53 mutations are the late events which mark thyroid progression into anaplastic transformation. Environmental factors such as long-standing iodine deficiency and radiation exposure in about 10% of the cases may play an additional role. The clinical features, usually the patient presents with a rapidly enlarging neck mass, which is often hard, fixed, and painful. And the tumor may invade the nearby structures such as trachea, esophagus, laryngeal nerves. That leads to all the symptoms of dysphagia, dyspnea, or even hoarseness. Unfortunately, the metastatic disease is common at presentation, with over 50% showing a lymph node involvement and about 40% showing distant metastasis, often to the lungs, bone, or the brain. The prognosis remains dismal, with a mean survival of less than 6 months, and the mortality exceeds over 90%. So when you grossly look at the organ, you see that there are large infiltrative areas which look like white tan tumor tissue, which often exceeds about 10 centimeters in size, and it tends to replace the normal thyroid tissue. So much like in the slide, you hardly see the normal thyroid tissue anywhere, and the borders appear irregular, and there is extensive necrosis and hemorrhage, which you will be visualizing in the slide as well. Microscopically, the anaplastic thyroid carcinoma is a widely invasive hypercellular neoplasm with extensive necrosis and remarkable pleomorphism. If you can see the cells here, they appear so bizarre. There are multiple morphological patterns which can coexist in a single tumor. So that is what you see here. Also, you are able to see some epithelioid areas, some spindle areas, some giant cell areas. You see so many giant cells, and there are some squamous variants, some paucicellular areas. These areas look rhabdoid here. There are some heterologous elements such as bone cartilage and rhabdomyoblastic differentiation also that can be seen in certain areas. The Ki67 proliferation index often exceeds 80%, reflecting some explosive growth rate of these tumors. Cytologically, it is very tough to differentiate on an FNAC because there's marked pleomorphism, mitotical figures can appear, there's some necrotic background that can appear on cytology. So the cell's immunohistochemistry is also a key differentiator. So in immunohistochemistry, they usually express cytokeratin, vimentin, and P53, while thyroglobulin and calcitonin are typically negative. Paxate positivity can be seen in more than half of the cases, especially in the epithelioid morphology cells. And P53 mutation is seen almost universally in more than 90% of the cases. Some cutting edge diagnostic features are some multiple genetic alterations which are somewhat helpful in the multi-step differentiation. So the key mutations include, like I already mentioned, TP53, BRAF, RAS, and beta-catenin. Other alterations include the PIK3CA, PTEN, CKN2A, and PCLAF. So these genes are notably overexpressed in the anaplastic thyroid carcinoma. The copy number variations that are commonly affected include the EGFR, FLT1, PDGFRB, etc., which drive the aggressive behavior of the tumor, and these can be potential targets for therapy. It is very important to diagnose this only after the differentials are excluded, because the morphological variation is too much. So the primary sarcomas of the thyroid, metastatic melanomas, some Riddle's thyroiditis, medullary carcinomas, poorly differentiated thyroid carcinomas also need to be placed in the differential. The key differentiators include the P53 positivity, high mitotic index, absence of thyroglobulin expression in the anaplastic thyroid carcinoma. The treatment is somewhat very difficult to treat because the early identification is the key. Surgical debulking, radiation, and chemotherapy are attempted, but the prognosis is pretty bad, especially for tumors that harbor the BRAF and PIK3CA mutations. Despite all efforts, surgical survival remains dismal. So, the 5-year survival is known to be less than 15% in most cases. So, to summarize, the anaplastic thyroid carcinoma represents the end stage thyroid tumor, uh, which is histologically diverse, clinically aggressive malignancy. So, the understanding of the nuances of the differential diagnosis and the molecular diagnosis is the key to differentiate from the other differential diagnosis. Thank you so much for your patient listening. Stay tuned for Dr. Deepa's Learning Launch for more such videos.